Dear audience, welcome to the complex exam. I would like to present my PhD theme, which is management of itching in the treatment of chronic spontaneous urticaria and prurigo nodularis. My name is Andrea Lancz, and I'm a second-year PhD student and also working as an internist at Markusovsky Hospital in Szombathely. I will make my PhD with the help of Department of Dermatology of Semmelweis University. My vision is that patients with prurigo nodularis or chronic spontaneous urticaria could have a better quality of life. Therefore, my mission is to optimizing the treatment of these diseases. Currently, I have two ongoing projects. The first one is about comparing the safety and efficacy of biologics in prurigo nodularis. Prurigo nodularis is a chronic skin disease that usually presents as very intensely itching nodules erupting on the extensor surfaces of the extremities and the trunk. Many associated diseases are known. However, it's not yet clear that these are background diseases or comorbid conditions. Only estimated prevalence is available, but the real number of the patients are probably higher. There are a lot of therapeutic options, but the conventional therapy's effectiveness is questionable, and some of the drugs may cause serious adverse events. In recent years, new biologic therapies have been developed, and in cases where the conventional therapies are ineffective or poorly tolerated, the use of biologics has shown promise. So our aim is to identify the best therapy for prurigo nodularis. Our clinical question is, what is the safest and most effective treatment in prurigo nodularis? Using the PICO framework, our population are patients suffering from prurigo nodularis, and we have compared the biologics to the conventional therapies, and we have measured the efficacy, outcomes, and adverse events. Our hypothesis is that biologics are more effective and safer compared to the conventional therapies. We have carried out a systematic search with these two domains and found almost 5,000 results, and after selection protocol we had 128 eligible articles. Here you can see our finished analysis, and now I would like to talk about my results. One of our main outcome was the changing of itch after dupilumab treatment. And the changing of itch was measured with the itch scales, with 0 to 10 itch scales. In this case, 0 means no itching and 10 means worst itch imaginable. And as you can see, after dupilumab treatment, the overall decrease of itch was almost 6 points. In the studies, more than 4 points decrease considered clinically significant. So this result not just statistically significant, but also clinically relevant. We have analyzed the studies at different time points, and I would like to emphasize that the more than 4-point decrease was achieved within 4 weeks. It shows us that dupilumab not just effective, but fast-acting drug. In my second forest plot, I would like to talk about the impact of dupilumab in quality of life. The quality of life was measured with the Dermatology Life Quality Index, which is a 10-item questionnaire with an overall achieving of 30 points. Higher score means worse quality of life. And as you can see, after dupilumab treatment, the overall DLQI decrease was almost 12 points, which is a statistically significant and clinically highly relevant result. In our next plot, I would like to talk about the incidence of adverse events in case of dupilumab therapy. As you can see, after dupilumab therapy, 13% of patients had adverse events, which considered a low rate, and I would like to emphasize that most of the adverse events were generally mild, such as conjunctivitis or local injection site reaction. And finally, I would like to talk about the therapeutic effect of conventional therapies. In these studies, the reducing of itching and skin symptoms was generally reported together. But we would like to wanted to compare them, so we have created our own unified categories. No response means that no therapeutic effect was achieved in the study. Complete response means that the maximal therapeutic effect was achieved in the study, and partial response means between anything in these two. With these methods, we could analyze two kinds of therapies, the phototherapies and thalidomide. And as you can see, after phototherapies, the complete response was achieved only 23% of the cases, and after thalidomide therapy, a complete response was achieved only 15% of cases. Of course, we couldn't compare these results with the dupilumab results, but we cautiously can say that this therapy seems less effective. Here you can see our status of my first project. And after our results, I would like to talk about the strengths and limitations. First, I would like to talk about the strengths. It is a comprehensive analysis of all existing therapies, and we have investigated a wide range of outcomes. But we have some limitations as well. The studies are very heterogeneous. We had small sample sizes because prurigo nodularis is a rare disease, and there were, as I mentioned, various definitions of the outcomes. Our conclusion based on our results that dupilumab is a highly effective therapy for prurigo nodularis, and phototherapy and thalidomide achieve complete clearance only in a few cases. We have some suggestion for practice. We think that we should use the dupilumab at an earlier stage of the disease. And we have some suggestion for future research as well. First, we need more comparative studies in the future, especially between biologics and between biologics and JAK inhibitors. And it's crucial to highlight that we need to investigate the long-term effectiveness of dupilumab and all the novel therapies. Here you can see my manuscript status. We have submitted it to JAMA Dermatology and currently under review. Now let me back to my second topic, which is investigating the safety and efficacy of biologics in chronic spontaneous urticaria. Chronic spontaneous urticaria is defined by the presence of recurrent urticaria or angioedema or both for a period of 6 weeks or longer. It is a self-limited disease in most of the cases. However, patients suffering from this have a low quality of life. The estimated point prevalence is 1%. And the first-line therapy for this disease are the second-generation antihistamines. But there are patients who are refractory for this treatment. In these cases, the use of omalizumab are necessary. Omalizumab is the first FDA-approved targeted therapy for this disease. Also, omalizumab has been an important addition for the therapeutic armamentum for the management of this disease. There is still a significant percentage of patients who doesn't respond to the combination of omalizumab and antihistamines. With the expanding knowledge of the disease, several novel therapies are in development and the preliminary results are promising. So our aim is to find the most effective treatment for chronic spontaneous urticaria. Our clinical question is, what is the safest and most effective therapy in chronic spontaneous urticaria? Our populations are patients suffering from chronic spontaneous urticaria, and we would like to compare the biologics to the conventional therapies. We will measure the efficacy outcomes with the urticaria activity score and the adverse events. Our hypothesis is that novel biologics are more effective and non-inferior in safety compared to the conventional therapies. Our clinical implication is to achieve the improvement of symptoms and quality of life of these patients. Here our topic is feasible, so our next step will be the Prospero registration. So these are our two projects. In summary, we have submitted the first and plan to submit the second in this year. Thank you for your attention, and let me say goodbye with the words of Captain Yemi from Black Clover. Even if you think you might lose, you will be fine as long as you don't give up. Surpass your limits, then a path will open up for you.
Thank you for this, again, relevant and very, very important clinical topic. Congratulations. What is the pathomechanism of dupilumab? What is the mode of action, and what are the potential side effects? Everything has side effects.
Thank you for your question. Dupilumab is an interleukin inhibitor. It's an interleukin 4 and 13 inhibitor. There could be several side effects, actually. I have mentioned the most frequent ones, but the frequent ones can be beside this, for example, the herpes infections, but these usually are herpes simplex infections, so herpes labialis, not zoster, fortunately, and one of the main side effects which should follow up with blood test could be the eosinophilia.
I frequently use methotrexate treating prurigo nodularis. What do you think about the efficacy of methotrexate?
Unfortunately, we couldn't make quantitative analysis regarding methotrexate, but we had a huge systematic review part, which we have tried to analyze the other therapies. And generally, I could think that the biologics are better, even better than methotrexate.
Thank you. And what do you think? Dupilumab is a lifelong therapy in prurigo, or what's your opinion?
Thank you for your question. It's hard to tell because dupilumab is a relatively new therapy. And we could use dupilumab in an advanced stage of the disease. It's worth considering the fact that we could, as I mentioned, we should make other studies that will investigate the long-term effectiveness. I think that maybe we should stop the dupilumab therapy if all the skin symptoms will heal. And I think that we should use dupilumab at an earlier stage of the disease, because an earlier stage, the skin symptoms can heal very quicker, and at an earlier stage there are fewer nodules. So I think, yes, it's worth considering.
Okay, thanks.
Congratulations. I would ask regarding to your first project that you mentioned that dupilumab should be given in the early stage of the disease, and why do you recommend this? And another question, in connection with it, that currently how is it administered?
Thank you for your question. Dupilumab can be administered from moderate to severe stage of the disease, both in Europe and both in America. But prurigo nodularis is a hard-to-treat disease, especially hard to treat when the disease is in an advanced stage. So we have a very good therapeutic options such as dupilumab. So if you can heal the patients sooner, why not? And patients who suffering from disease and hard to treat have several hospital treatment. So I think the overall cost is lower when we treat the patients sooner.
Thank you.
Thank you.
Very nice work, congratulations. Just a methodological question. I saw that you showed for dupilumab changes from baseline, while for the standard therapy, some proportions of treatment response. Are there no direct comparisons between them, or why did you choose to present the data in this way? And what is the proportion maybe of complete response, partial response for dupilumab, if it's comparable or better? Or
Thank you for your question. We have tried, but we couldn't compare them directly. The studies regarding thalidomide or phototherapies are older studies, most of them older than 10 years old. And we have now new tools like wash score in case of itching, or nodule scores, or life quality scores, which wasn't used in these studies. And in the studies, the reported outcomes were unified, the study, the individual study, and usually it was reported as an overall response that the reducing the itching, the healing of the nodules, and this was reported very heterogeneous. There was study where there are 5 categories about this. There were study where there are 2 categories about this. So we could only make these categories, and there was how to say it? There was very different kind of reporting than in the new studies.
just to have an idea, or maybe it's not quantified like this, with dupilumab, what is the rate of response overall? I understand that it is for more severe cases, but is it also a high rate of response? What should we expect, let's say, from this treatment?
It is a very high efficacy therapies. Yes, it's very good, and in most of the cases, almost complete healing was achieved.
We know that omalizumab is a very effective therapy in chronic spontaneous urticaria, but what do you think? What is the effectivity in inducible urticaria? Have you idea about?
In case of omalizumab efficacy?
In inducible for example, cold urticaria, or what is the efficacy? Is it a good therapy in cold urticaria or other types?
I think that inducible urticaria, the first line, not treatment, but suggestion to avoid the
trigger. Yes.
Yes,
that's true.
I think it could be it could be an effective therapy, because the pathomechanism is not so different.
Yes. Rituximab in urticaria. I don't think so. Maybe if there is some hematological, yes, if something behind the cold urticaria, yes.
May I ask one more question? You mentioned this chronic urticaria, that there are new agents also. What are they, and how does they work, and what is the pathomechanism again for the new ones, not the omalizumab, the other ones?
One of the new agents are remibrutinib, which is a BTK inhibitor, and the second one is ligalizumab, which is ACT-line kind of omalizumab, but it also binds the free IgE, but binds better.
Can we just scroll back to the forest plots, please? Yes, this one here. So, for example, you have that one in the lower bottom right, and it ranges from almost 0 to 1, or not 1, but up to 0.6. So it seems to be like almost a smooth coverage of the whole range between 0 and 0.6. Could you find any explanation for that?
Sorry, could you?
In the lower left corner, if I look at the individual study outcomes, it seems that it's like super heterogeneous, like it smoothly covers almost all parts of the range from 0 to 0.6. Do you have any explanation for that or suggestion?
Well,
complete response rate, right?
Okay. Well, there were several study types, not studies types, study, how can I say,
arrangements or
yes,
designs.
Yes, study designs. There were retrospective studies, some of them were prospective studies, and some of them were retrospective studies which investigated a long time. One of the studies investigated a short time period. There were different kind of comorbidities of the patients, and the outcome reporting were very heterogeneous too. So I think maybe this could be the...
I definitely feel that needs explanation. Like you have response of 0 up to 55%. It's like, I think it's very clinically interesting. I mean, I would rather be in the 55% response team.
I'd like to congratulate on your project, and my question would be, is there any like a promising biologic for the treatment of prurigo nodularis beyond dupilumab?
Yes, thank you for your question. One of the main agents is the nemolizumab, which is an interleukin-31 inhibitor, and this is the second FDA-approved therapy for prurigo nodularis. For this disease, for prurigo nodularis, and the JAK inhibitors are promising too. For example, baricitinib, tofacitinib, or upadacitinib.